Okay, so I have two disclosures besides what's in the slides that I want to make sure that I get to. The first of which, I'm going to go back to the title slide. I'm a bit surprised that no one else has been freaked out by the fact that Dr. Kachami is looking over your shoulder and straight at you while you're giving the lecture. It's really weird. And I've been thinking about this and losing sleep at night, what this was going to feel like, and it's just as freaky as I thought it was going to be, Dr. Kachami, so thanks so much for that. Um, the second of which is that the last two courses I've spoken at in the past month, I've been the first lecturer of the entire conference, or the first lecture of the day, and you're just hoping people are caffeinated. And now I'm at the very end. Dr. Sharma, you have the honor of being the absolute ultimate, but as the penultimate, I'm thinking, gosh, this is such an interesting juxtaposition from my prior experiences. But if you're thinking that you're going to see a ton of data and hard information, no. Dr. Gorgon took care of that, Dr. Lynn, they had great stuff. I'm going to wax philosophical because I think it's good to sort of step back and get some perspective as we sort of start to come away from this course and think about how each of the different pieces contributes to the multidisciplinary management of this very important and deadly disease. So I'm going to walk you through the endoscopist's history in esophageal neoplasia from my perspective. In the early days, right, what could we do with endoscopy when it first came out? Fiber optic scopes, basic scopes. Dr. Zafashia right here, you remember the very beginning, you could take a look. You could say, hey, I see something, and then do nothing else, right? And then we got a little bit later, we could take a biopsy. We could say, oh, let's take a piece of something and give it to another doctor to take a look at and figure out what's going on. But therapeutics, interventional, that took a while to come through, right? So the idea of the endoscopist's role, and I think that there's been some bias from other specialties over a long time as our tools evolved, was more seeing the endoscopist as the diagnostician and just getting you the tissue and then sort of relinquishing, stepping back and letting others jump in and take the lead. And that's really changed over time. And as somebody who does a lot of work in Barrett's esophagus, you go back and you read the old guidelines where basically you endoscope the patient, you looked for dysplasia. If you found dysplasia, you maybe checked them a little bit more frequently. And then if you found a lot of very advanced dysplasia or really more early cancer, you turned it over to the surgeon for an esophagectomy, which we've been hearing about in the last talk. And, with early endotherapy not being particularly efficacious, particularly well tolerated, carrying some significant risks of adverse outcomes, people did not really push that very much. But only with our newer therapeutic regimen in the 2000s and later with PDT and then RFA and cryotherapy and endoscopic resection did the guidelines on the GI side, and I think across into the NCCN and some of the other organizations as well, moved more toward inclusion of endotherapeutics. That was really a seminal moment for us where we went beyond just sort of making a diagnosis and then letting somebody take over to saying, hey, keep us involved in the game here a bit. And I think you've heard about that a lot in the last couple of days. So where are we today, just to remind everybody? Well, I think we can play and we should play a critical and expanded role in the management of esophageal disease that in the past, as I said, would have been sent for esophagectomy. So where's our involvement as endoscopists? It's really throughout the life cycle of this disease process, from initial diagnosis and staging and saying, is it even possible to consider organ preservation in this patient? Delineation of the lesion, again, following on that same theme, and helping to guide the initial therapy if it's not being done endoscopically, or if it is it something that we can do as monotherapy, or does it require a multimodal approach? Evaluation of therapeutic outcomes and restaging of the patient is certainly something that we know from PET scans and CAT scans and MRIs is not something that imaging can do as well as us taking a look and likely taking a biopsy. Right, and post-treatment surveillance to look for recurrence as well, especially early recurrence, and palliation when a cure is not possible, because healing doesn't always mean fixing. It means making the intervention to really help the patient where they need us. And so to me, endoscopy can play a really important role throughout all of those different aspects. And I think That is a seed change for us on the esophagoscopy side that just 2 decades ago would not have been an area where we would have been recognized for those contributions potentially to the care of the patient. And I think this works in benign conditions as well, and we'll talk about that briefly at the end of the talk. So you've heard some great discussions, and I'm sure that Dr. Gorgon didn't realize he was giving an esophagology talk when he went in and talked about ESD and endoscopic resection, but making that tissue diagnosis and then trying to remove the diseases is very similar, dirty end and clean end to the GI tract, right? And so we can look at using all different kinds of methodologies, from forceps and brushes to endoscopic resection kits, or even going in with a fine needle to take an aspiration or a biopsy. And again, is the diagnosis that we come up with and the extent of disease compatible with organ-sparing interventions. This is some data that we can give to those of you who are not endoscopists very early in the process, right? And that can be through endoscopic ultrasound, as we've talked about in this conference, looking at the deep margin of our resection specimens and thinking about how those results can influence the care plan for the patient. Certainly delineating the lesional extent is very helpful, and I would argue here that gastroenterologists in general do a relatively poor job of describing our findings. We can take pictures, and our pictures are better now than they used to be, but I'm really continually amazed by the fact that I get an endoscopy report for a patient who's coming for a second opinion, and it says a mass was found in the lower esophagus, biopsies were taken. That's it. Right? No measurements, no clock face, no appearance, no concurrent features, nothing. Right? And so we as gastroenterologists need to do a better job of that to help all of you to understand what we're looking at better. And a picture is worth 1,000 words, but a picture on an endoscopy report that's an inch and a half by 2 inches is not going to do the trick for you when you're making life and death decisions. So we recognize that, and I think we all have to do better within our own discipline on that. And, again, accurate determination of size and anatomic positioning will also help as we get into tumor boards and start talking about what's the best way to approach this patient. What's the optimal surgical approach? What's the way that we could treat? Where the beams line up for radiation, right? And thinking about our ability to help guide those processes by placing things such as fiducials, tattoos, or clips to help with all of those processes. But, and this is where we like to put on our I want to be a surgeon hat, right? How about cut it out, right? I was taught in medical school, when in doubt, cut it out was the surgical mantra, right? So sometimes we want to raise our hands and play in the sandbox too, along with you guys. And so if we can do that, and I think you've seen some great examples over the last couple of days of things like endoscopic mucosal resection, which are good all the way down. It's really a misnomer, right? We can get down to SM1, or endoscopic submucosal dissection for deeper lesions and larger lesions. These are ways that we can really, again, provide two terrific things. One is we get you a better diagnosis because with more tissue and generally a single specimen and a deeper specimen, we can get you a lot of that valuable information we just talked about. But also, this can be therapeutic, right? And we can really go back to the drawing board about how we're going to manage the patient based on what the findings are of this initial attempt to remove the lesion. And just as a quick reminder, although you've seen data out the wazoo on this in the last couple of days, right, that EMR is really good for smaller lesions, ESD for larger lesions, and you can see that this is an ongoing debate in GI is the best way to do it. I would argue that if you have a lesion in the lower esophagus that you think might be an early cancer, the deep margin is much more important than the lateral margin, because if you take multiple specimens with an EMR, you're going to have a positive lateral margin. You just have to know how to deal with that. If you're able to get the patient to someone who could do an ESD and take it out on block, that's great, but time is sometimes of the essence too. I think the deep margin's more important. EFTR, as you've seen before as well, a really great new way to do this for those folks who can get in and really, this was unthinkable when I was going through my training that we could, as gastroenterologists, do this for our patients, but it's fascinating how things have evolved in such a short period of time. And adding on to EFTR is STIR, submucosal tunnel endoscopic resection, where we can go and get lesions that are deeper in the esophageal wall that we've seen on advanced imaging, or you've got normal overlying tissue, and basically use the same thing we would do for a Poland procedure in achalasia to go in and take one of these lesions out by tunneling into the submucosal layer and going ahead and removing that lesion. It's pretty remarkable, and it's really neat to see it done. And I encourage those of you who use the scalpel to go ahead and see watch your advanced endoscopist do some of these procedures. It's really mind-blowing and very creative ways that our leaders in this field have come up with to be able to provide this option for patients. And then once you've gotten that focal lesion out, field ablation, as we talked about at lunch in the cryotherapy discussion, I think is super important. There are a whole bunch of different approaches to this that are out there. I've mentioned them, listed them on the screen here. You saw some really neat demonstrations of these throughout the course of the last couple of days. I will remind you that radiofrequency ablation, RFA, that we use it in the esophageal context, right? This is the Barrett's procedure, is really great for flat lesions, but it should not be used on anything that's a raised lesion. And so if you have a gastroenterologist who is working with you who is trying to RFA an esophageal nodule or cancer, that's really the wrong approach. So please make sure that they're using the technique appropriately. For those of you who are not in the luncheon, just a brief reminder what liquid nitrogen spray cryotherapy, or LNC, is. Basically using very, very cold, minus 196 degrees centigrade liquid nitrogen that's passed through a catheter that's advanced through the working channel of the endoscope that provides a very rapid and efficient energy transfer of about 25 watts per treatment, and a laminar flow low pressure state out to the tissue. And there is, unlike other therapies, no need for direct tissue contact. It's like, as I say, frost on a cold fall morning. As long as the tissue gets cold enough, the energy transfer occurs, and then the treatment effect takes place. So you can treat in patients who are on blood thinners, you can treat on patients who have a stent in place or other hardware or appliances. You can treat in patients who have a large scar from a prior endoscopic resection that does not have a flat surface on it. You can treat in patients who have a distorted anatomy and tortuous esophagus from a giant paraesophageal hernia. You can treat lesions that go over the lip of the EG junction and into the cardia of the stomach and beyond. It's really a very flexible ablation platform, and it is included in the NCCN guidelines, as we talked about in lunch. And I mentioned at that time the meta-analysis that my team and I had done to look at its efficacy in early stage esophageal cancers as part of a multimodal approach when necessary with endoscopic resection, and saw some very nice results with complete eradication of cancer in 2/3 to 3/4 of patients, depending on the studies. I hope some of you got a chance to see nitrous oxide cryoballoon during the demonstrations earlier today. This is a little bit different technique. The cryogen is deployed within a soft, pliable balloon. So there is, it's really a self-contained system, again in a lower pressure system, but you have to make sure that the balloon wall contacts the desired tissue so that the energy can be delivered. And you saw that they have new catheters that allow you to work in different configurations, whether a focal spray or 180-degree hemicircumferential spray as well. Perhaps because of the distension and of the tissue with the balloon, they do have a little bit higher stricture rate compared to the spray cryotherapy, but has been used very nicely both in a malignancy setting and a pre-malignant neoplastic state setting as well for dysplastic Barrett's and non-dysplastic Barrett's. But it's also been used for esophageal squamous neoplasia, as many of us have also used the liquid nitrogen system. So these are ways that we can get in there and potentially eradicate this disease in the earlier forms as a primary therapy or as a salvage therapy when other things don't work, as was mentioned before. And these are both very well tolerated and relatively efficacious treatments. PET is one that sort of was around and was the predecessor to cryotherapy and RFA for Barrett's before the phase shift. But for those of you who are familiar with how this is used, basically a chemical photosensitizing agent is injected through an intravenous approach, and then the patient undergoes endoscopy where a red light is turned on that activates the agent, and basically through release of oxygen-free radicals preferentially destroys the tissue where that collects, which is generally the abnormal tissue. Problem is that you get about 6 weeks of very severe photosensitivity, so Las Vegas doesn't seem like the greatest place to be able to deploy, or Phoenix for that matter, I guess. So you've got to dress like the Unabomber, for those of us who remember the Unabomber and what he looked like, until that photosensitizing goes away. And most of the patients have pretty significant pain, so you've got to think about admitting them for IV narcotics until that starts to wear off a little bit. But it is a very nice approach that can be considered, and it's sort of getting a little bit of a renaissance now in the cancer realm, showing its ability to remove some of this disease. So just another one to throw in there, because you may be seeing that even a little bit more now with some resurgence in the cancer context. But as Tufik and I were talking about before this course, and I think I mentioned this in the cryo talk over lunch, multimodality therapy, I think we're hearing from this course, this is really, really the future. And we have to think about how all of these different pieces, whether they're endoscopic techniques, whether it's cryotherapy, or whether it's chemotherapy, immunotherapy, radiotherapy, things that we haven't even thought about yet, right? How they're all going to work together in different pieces. It's just not going to be pick one gun and shoot it. It's going to be, let's put the whole battle plan together, and let's be prepared with multiple different resources from our armory to go out there and have the greatest chance of success. So, really something important from my perspective. And if we're not successful in reaching a cure, as much as we want to cure every one of those patients, palliation is really important. And it's important to remember that when we get into that context, that we need to talk to our patients about what their goals are, right? We need to know, what does it mean to them if you're going to go for more treatments? What are your high priorities, right? Is it being able to eat? Is it being able to be at home? Is it being able to have more time? Is it is it not being in pain? There are so many different things, and if we ask those questions at the outset, we have tools that we can use to preserve organ function, if not to preserve the organ itself, right? From endoscopic stenting to cryotherapy to PDT, perhaps laser, some of the other techniques that you saw earlier, right? Ways to reduce the tumor burden and maintain the ability of the esophagus to serve its primary role, which is to be a conduit for food and nutrition between the mouth and throat and the stomach. And so we can look at endoscopic stenting. There's a lot of advancement, and there's an awful lot of stents that are out there, and I'm not going to bore you with all the details of them, but it's important to recognize that they can be used for both benign and malignant conditions. They come in different shapes and sizes because esophagi come in different shapes and sizes, and disease processes change that anatomy in different ways. In the right context and with the right equipment, they can be removed if they are creating undesired effects, or they are not creating the desired effect, and they may need to be replaced as the therapy is successful and it's time to upstage to a larger one to provide even better relief for the patient. I will say that in the setting of esophageal cancer, my personal experience has been the patients experience quite a bit of pain with this, and with esophageal adenocarcinoma that preferentially occurs close to the esophageal gastric junction, stenting across the junction makes that patient a conduit for very significant gastroesophageal reflux, and therefore aspiration, which can create a lot of discomfort and potentially adverse outcomes for the patient. So I try very hard when I'm working with my oncology team and the other interventional endoscopists who do a lot of stenting to think about, is the opportunity here for us to be able to focus more on alternative ways, such as liquid nitrogen cryotherapy, palliating malignant dysphagia, which a lot of other folks have done as well. And here you could see the systematic review and meta-analysis of this that we also spoke about in lunch. But it also can be used for benign strictures. And in fact, what we've learned is that pre-treating the stricture with, whether malignant or benign, with cryotherapy to sort of hit the reset button on the extracellular matrix allows for a more durable response to maintaining luminal patency after the cryotherapy and then dilation are performed in the same endoscopic session, as compared to just doing cryotherapy or just doing dilation by itself. And I will tell you that this is certainly true for me in my practice, and I know that there's more data coming out on it, but I wanted to show you this really nice poster that data that had come out now several years ago, but there's been several more since that. But more important for me is to put this in a patient context. This is a patient of mine who I treated back in Philadelphia many years ago now, who first was diagnosed with adenocarcinoma arising in Barrett's back in 2004, had a partial esophagectomy and did fine for about 5 years until during surveillance endoscopy he had a nodule seen at the anastomosis for which he received chemo XRT. Did not tolerate it well, but it did get rid of the lesion for a short period of time, maybe about 6 months or so, maybe a year. And then another endoscopy identified what was billed to me as a 1 centimeter nodule that had adenocarcinoma, invasive adenocarcinoma on biopsy. And so the patient had already had surgery, he'd already had chemo and radiation. And so he was sent to me sort of, put your affairs in order, go see if Smith can do something for you. And after 3 treatments, 1 month apart of liquid nitrogen cryotherapy, you could see that we were able to massively reduce the tumor burden from what was billed as a 1 centimeter nodule, what was 3 to 4 centimeters in maximum diameter when I saw him just a week or 2 later, to something that really wasn't getting at all in the way of the esophagus at the level of the anastomosis. And in fact, he came back on a monthly pattern, and at 12 months and 24 months, you can see very minimal change from where we were with negative PET scans throughout that interval as well. Unfortunately, his wife didn't drive. He felt very guilty asking his neighbor to keep bringing him down every month and started to take holidays, and that unfortunately led to things sort of rearing their head again as he got off the treatment course. And after about 30 months, we put a stent in and put him into a hospice program, and he passed peacefully with the family at his side. But he pulled me aside when we were doing our last endoscopy, and he said, you know, I never expected to spend this much time with my family, with my wife, and to be able to do that and just come to see you once a month, even though it was a tough trip, it was all worth it. And I've had several cases like this, but I wanted to show you this because even though, you know, this is about organ preservation, it wasn't a permanent preservation, but boy, it was a really meaningful preservation from my perspective. And so for putting this all together, to me, the endoscopist plays a major role in organ preservation for both malignant and benign disease, from initial characterization of the lesion all the way through endoluminal treatment and perhaps cure or palliation. Newer endoscopic techniques for resection that we've seen here in this course and field ablation really open the door to successful eradication of the disease and preclusion of esophagectomy. And especially with esophageal neoplasia being found in younger patients, as well as those who don't fit the traditional demographic of esophageal cancer patients that we thought of in our training, you know, just a few decades ago. It's really important to collaborate with the patient and other members of the care team to arrive at a personalized, optimal treatment plan, because the patients just aren't thinking about the disease the same way and the same way as that we're doing it. And so we need to include them as part of the collaboration that we've been discussing the past few days. So thank you all very much, and looking forward to the discussion.